Hello, everybody. I'm Bruce Mueller. I'm the Interim Dean of the College of Pharmacy at the University of Michigan, and welcome to the very first episode of In the Interim. This is a program that we've put together mainly for our students to make sure that even though we're in this crazy era of COVID, you have a chance to do some networking with prominent alumni, prominent faculty members, other guests that we may bring in related to the College of Pharmacy, that you get a chance. We're going to try to do this once a week and you get a chance to ask questions your very self to these folks, things you always wanted to talk about. You can get your networking practicing going on right now using this program in the interim. And I'm really pleased to have our very first guest ever is our very newest faculty member. It's Lydia Benitez, who is a clinical assistant professor here at the College of Pharmacy. She is a graduate of our program, and she is currently working at the University of Michigan in the hematology oncology, as a hematology oncology pharmacy specialist. She did her PGY1 and PGY2 here, left us to go to the University of Kentucky for a while, and we'll talk a little bit about her career path. So I really wanted to welcome, and thanks for coming, Lydia, to the very first episode.
Thank you for having me.
But I want to start every one of these episodes talking about people's crazy backgrounds. Everybody can see my background. It's my house. So welcome, audience, to my house. Here we are with as fancy as what my messy office looks like. But your background looks a lot different. Give us a little bit about what that is.
Sure. So I picked this background for three reasons. One of which is that this is the last thing I did before COVID. And literally meaning probably, I think this was March 12th, and I was in Puerto Rico, which is the second reason. So I'm originally from Puerto Rico, and we had planned a trip to go back home at the beginning of spring. And so we went home and I went climbing, which is the third reason why I included this background, because I know you like hidden talents. I know that when I was a student, you taught us about hidden talents that the faculty had. And so this is my newest, I wouldn't say it's a talent yet, but it's a hobby. And so me and my husband went to go climbing in Puerto Rico. And then when we were there, we started hearing that there were cases of COVID being reported in Michigan. And we flew back, and literally the day after we flew back, they actually closed down the airports in Puerto Rico. So I was really close to spending COVID in Puerto Rico, which maybe wouldn't have been the worst thing ever.
Yeah, well, but you might still be there for that matter.
Yes.
So well, thanks for sharing that. And there's a little bit more about your background I want to explore, but I want to tell the audience that you're going to have the opportunity to ask questions. There is a Q&A feature that you can use here in this webinar that we've got set up here. And at the end, I'm going to open up the Zoom board here so that if you've got questions you'd like to ask live or have a conversation with Dr. Benitez, then you can do that as well. So either way, if you're shy, you want to type in a Q&A, or you think I've missed something, put it in. Otherwise, feel free to I will give you a chance to ask questions later. So you're from Puerto Rico. How does a nice girl from Puerto Rico end up in a cold place like Michigan?
Ironically enough, to play golf. So.
I knew that, and so I am wearing my College of Pharmacy golf shirt here just in your honor. That's why I put that on today. So tell me how you come here to play golf, because it seems like you're going in the wrong direction.
Yes. So I, born and raised in Puerto Rico, and I was trying to decide during my senior year where I wanted to go. I knew I wanted to do something in the sciences, so I was looking for strong science programs that had a good golf team. And so I was looking to get recruited and ended up at Michigan. It was between Michigan and Penn State or UNC. So somehow Michigan won out. I came to visit on the coldest day of the year. It was like January 13th of 2005, and it was freezing. And somehow that didn't scare me. And I thought snow was beautiful because I'd only seen it once before. And the rest is history, I guess.
But you didn't know then that you wanted to go to pharmacy school.
No.
So
my mom is a pharmacist.
Your mom's a pharmacist. Okay.
So I did a lot. I always knew I wanted to do sciences. I actually explored a lot of different paths. I thought about engineering for some time and was in the College of Engineering, but I realized that I wanted to do more science than math, even though I like math, but I wanted to do something where I could apply the science to patients and do some translational work. And So in talking to I did a lot of undergrad research, and in talking to some of my professors, I started realizing that I really like chemistry, and that pharmacy, honestly, it was 4 more years of learning about a profession. So it kind of, even though I didn't know exactly what pharmacy was, it allowed me to continue to explore that interest in science, in taking care of patients, and in chemistry. And so honestly, I picked pharmacy because it seemed like the doors would open very widely and I wouldn't pigeonhole myself into one specific career.
Well, your career, is it different than what your mother had or has?
Absolutely.
Yes.
Absolutely. Yes.
Okay.
Yes.
So today, well, you graduated, you got your PharmD, you did a PGY1, PGY2, and you were our chief resident, were you?
Yes, for PGY 1 year, yes.
And what does that mean you really do? It's like when our students are looking at this, do they want to be the chief resident someday?
Well, I think that there's some really good opportunities for the chief resident to affect change. And so one of the things that I got the opportunity to do was sit at all the Residency Advisory Committee meetings. And so I got to see how RAC works. How do you run a residency program?
RAC is the Residency Advisory Committee.
Right, right. So I got to see where all the directors sit and the things they talk about and the things that we as residents don't recognize are happening in the background. And so that was interesting. And also, I got to voice some concerns of some, fellow residents. Like, for example, our on-call program is something that we really wanted to work on. And so through being in that leadership position, I got the opportunity to affect change there. It is a lot of work, and it is a lot of scheduling as well. But I think every time you have a good opportunity, it's like you said, there's no free lunch. So there's always going to be something attached to it. But I thought it was a great opportunity. I'm really glad I did it.
All right, so in your PGY2 year, you decided to go into the oncology side, hematology, oncology side of things. Tell us what was your research project as a resident?
So my second year, my research project was looking at olanzapine, and it was novel back then, and now it's standard of care. It was looking at olanzapine as not as an antipsychotic, but actually as an anti-nausea medication for patients who were getting an allogeneic stem cell transplant, an autologous stem cell transplant, who were receiving melphalan conditioning. And so it was the idea that olanzapine is maybe a really good antiemetic, and we should be using it in these patients. And that's actually exactly what we found. And then nowadays, there's been prospective studies on this, and it's actually standard of care for highly emetogenic regimens.
But you're the first one to come up with that. Okay.
Well, not the first one, but definitely one of the, it was definitely novel at the time. Okay. And I have to thank Dr. Frame because he always is about 10 years ahead of his time, and he was the one who was doing this.
He still is, by the way.
Of course.
So but anyway, you graduate with this PGY2, or you leave us with this PGY2, and next thing you know, you go and leave us. Tell us about the next step, and talk about somebody who's been in Ann Arbor for 8 years, and you didn't go back to Puerto Rico. You did something totally different again.
Yeah, so I loved Michigan, and I knew that my home was Michigan. It felt like home. And it's funny because when I decided to leave again to come back, my boss told me, "You're going home." And, but at the time I knew that I wanted to practice in hematology, and there was a really good opportunity at the University of Kentucky. I'd always looked to that program when I was looking at pharmacy school, when I was looking at residencies, because they have a really, really strong competitive program and really strong pharmacy presence. And so it was an opportunity to go see something different. I think there's a lot of diversity that you gain when you go somewhere different, where people may something that you take for granted, that you think is standard of care because everyone at Michigan is doing it. You may go somewhere else and, everyone may be like, "What are you doing? Why are you doing that?"
Well, that's right. I mean, I tell the students that the University of Michigan is not the real world. I mean, you don't know how good you have it in a lot of ways, but also people think the same way. So to see something different is probably a good thing. Mm-hmm. We had an audience member ask the question, how in the world do you choose hematology of all the things? Why would you choose hematology?
That's a great question. It wasn't easy. I was the PGY1 resident that was interviewing for 2 different specialties at the same time. I was looking at infectious diseases and oncology. And the reason why is because I knew I wanted to take care of immunocompromised patients. I loved infectious diseases, but I really liked fungal infections and people who come in and have, a neutrophil count of 0. And when I did my oncology rotation in hematology, and I was very lucky that, Dr. Bernard Marini, he saw that I liked
Do you
that.
call
So
him
that,
Bernard? Do you really call
well,
him
no,
Bernard?
Bernie Marini.
Bernie, okay.
We had chatted, and I told him that I liked immunocompromised patients, and he said, you have to do MHE, you have to do hematology, you will love it. And I really didn't know much about it, but as soon as I stepped into that world, it was the perfect application of the immunology and the infectious disease component and a little bit of critical care.
A little
And,
infectious disease, little nutrition, a little just about everything. Yeah, I agree. That was my favorite rotation for the same reason. It's we didn't have very many drugs back in those days. It was just mostly leeches. But yeah. So all right. So hematology, it's you did it because of the challenge. And how many years were you at Kentucky?
I was at Kentucky for 2 years.
And then you came back here, and how long have you been back?
I've been back for 2 years.
You've been back for 2 years. Oh, you have to stick around. You can't leave your job every 2 years.
I
It's
will
not good.
not.
All right, that's a promise. We hired you as a faculty member, and one of the things I wanted to get to and talk about here was I told you that your interview seminar was the best interview seminar I have seen in my 30-something years of watching interview seminars and training people to do them, and I thought it was great. And one of the things I thought was great is I'm not a hematology person, but you started speaking. You took your very complicated story and science, and you made it in a way that you communicated to somebody who's been as far out of hematology as I am. And you really made it make sense. And you talked about in your research about oncology stewardship. And we talk about antibiotic stewardship all the time, and I understand what that is. And we're using antibiotics in a way smart, keep down resistance, keep costs down, all those kinds of things. We learn that in pharmacy school. We teach that in pharmacy school. I had never really heard the term oncology stewardship. Why don't you talk to the audience a little bit about what that is and what do you mean by it?
Sure. So oncology stewardship is something that, to be honest, it's very new also in the oncology field. And when I started thinking about it was in the context of giving a presentation at Kentucky about new therapies. And so what's been happening in the world of oncology is that there's so many therapeutics that are getting approved, and it's an explosion. So like in AML, for example, there's 8 new approvals in the last 3 years. And what is different is that when you approve things for oncology, we have this concept of therapeutic monopolies and of price inelasticity, which are concepts that we typically associate with economics. And that
explain some of those to us, will you?
Right. So, price inelasticity is just the idea. If somebody has cancer or any disease, we're going to pay however much it costs to treat, right? We're not going to bargain with the company, or at least we're not used to. That's not how our economics work. And the therapeutic monopolies is the idea that in oncology, you very rarely cure patients, especially in hematology, or in metastatic solid tumors. So what ends up happening is that every new drug approval, instead of competing against each other to be the best, they compete to have a piece of the pie, of the oncology pie, right? So drawing an analogy to ID, we know that if we have 2 drugs to treat MRSA, you have linezolid and you have vancomycin. Well, you're gonna make a very easy choice based on efficacy. If linezolid is no better than vancomycin and the side effect profile is worse, or if it's more expensive, then we know that vancomycin is going to be our choice because it's very easy. It's, they're competing for the same endpoint, which is to cure the patient of an infection. In oncology, although that should be the endpoint sometimes, it's almost never the endpoint. And so what you end up is with trials where the standard of care is not really what we would call the standard of care. And so now you have all these approvals for all these new agents, and you have a menu of options. And it is really the role, I think, of the pharmacist to elucidate which is the best option and to poke holes, in some of the trials that get these drugs approved, use those evidence-based medicine skills to do so. So that's the concept of oncology stewardship. It's really, it's looking at the data. It's a coordinated set of strategies. So it's looking at the data, doing research, also trying to implement formulary restrictions, promoting the concept of stewardship so that people are aware of it, with the goal of enhancing patient outcomes and reducing financial toxicity, which is ever so important in our healthcare.
We don't usually use the word financial toxicity, but I kind of like the idea. I always think of nephrotoxicity. You got financial toxicity. So you use the word endpoints, and that the endpoints aren't always so clear. What are the endpoints that are used maybe by the advertisers of who make medications versus what are the endpoints you think are important as a clinician, or what do patients think are important?
Right, sure. So overall survival is, I think, the gold standard, right? We want a therapy. If we're going to introduce a new therapy into the market, it should be a therapy that increases the survival of patients. So for patients with AML, their 5-year overall survival is 20%. So we want to make a dent on that. And for some patients, getting them beyond the first year, that would be meaningful.
What's a dent? We always talk about statistical significance versus clinical significance.
Right. I think that's definitely in the eye of the beholder, right? But
if you have the cancer, you might have a different answer than the person taking care of you.
Absolutely. And some drug companies, statistically significant is a month. And so you have to ask yourself, is a month really clinically significant when the patient is not having a better quality of life? And so those are the kinds of things that, you're looking at the endpoint of overall survival, but you have to look at multiple endpoints together. So is the overall survival better? Yes, no. And in that time that they have that it is better, did the patients have a better quality of life? Were the patients in and out of the hospital? Also, when you look at overall survival, a lot of times it may look better than the comparator, but when you read what the comparator was, it wasn't actually the standard of care. And so the study itself is not externally valid to what we actually do in clinical practice. And so I think that those are the kinds of things that we look at when we're looking at oncology stewardship. So the endpoint is important, but also the context of how the study was designed to arrive at the endpoint.
And in your practice, how often do you involve the patient in that conversation?
I think we don't do it enough. So I work in the clinic now in the outpatient setting. So I work a lot with physician assistants and then the hematologist. And so the physician assistant and the pharmacist usually team up, and we say, hey, you're talking about this third line agent for this patient that the probability of response is less than 10%. And even if they respond, their median overall survival is 6 months at best, of which they will become transfusion dependent and be coming here for platelet transfusions 2 to 3 times a week that entire time. Have you talked to the patient about that? And so, it is a very difficult conversation to have because it's a very intimate conversation that you don't want as the pharmacist to be the first person to have it if the physician hasn't had it. So you have to respect that bond between the physician and the patient and make sure that you do it multidisciplinarily. So a lot of times when we are having those more difficult conversations, I will go in the room with the physician and, we will feed off each other, or I will ask the physician, what did you tell the patient? And then expand on it. And the patients do ask. A lot of times, if the physician does not tell the patient what the probability of response is or what is it going to look like, the patient will ask me because I sit with them after and tell them what they're going to experience. I do a lot of education for that purpose to ensure that patients really understand what they are consenting to.
So you mentioned before that you want to make your decisions based on evidence-based pharmacy, evidence-based medicine. But an important part of that is you got to make new evidence, particularly if you're a faculty member at the University of Michigan. So can you give us an example of maybe some research that you've worked on recently or working on now that's looking into this oncology stewardship idea?
Sure. So there are several projects that we've done as a group. And so within, I'm very lucky to have 2 awesome colleagues in hematology to work with, and they really are so smart with research. And so together we come up with all these ideas. And so we've been working a lot in secondary AML, and so secondary acute myeloid leukemia. And in that space, we've been looking at basically we're trying to figure out what the best way to treat these patients is, because these are the patients that really median overall survival is 10 to 12 months. So one of the things that we worked on was we did a multi-center retrospective research project where we got 7 different institutions, a lot of them very large cancer centers like, MD Anderson, Utah, and Rochester. We had like a lot of different big cancer centers. And what we did was, there's a drug that's standard of care now. It got approved on the basis of a study that we believe to be not externally valid. And there's a lot of reasons for that. And well documented, there's a lot of commentary, expert opinion that is true. And so what we did is we compared it to a different regimen, which we use called FLAG. And we did this study to show, our goal was to see, is FLAG, which is a very inexpensive old regimen that it has data for secondary AML, just as good as this shiny new expensive drug in terms of efficacy. And so we were looking at short and long-term efficacy, so complete response rate and overall survival. And how does the safety compare? And so what we found is that efficacy is just as good. And from a safety standpoint, FLAG is actually safer. And that translates to patients feeling better when they're on therapy. So if you're not going to improve overall survival, at least you should improve quality of life. And so that's a big study that we completed. We presented the results at the last year at the American Society of Hematology conference. And we are in the middle of working with, we've submitted it. We're working through edits and trying to get that in manuscript form. But along with that, we also have smaller projects that we hope to bring to the multi-center arena in the future, but we're piloting them. So typically we do a single center project first to see if we're in the right track, because we want to make sure that as an institution, we're treating patients the right way. And then we go out and expand. So one that we did as a pilot was looking at, again, that regimen FLAG in secondary AML versus a different regimen called the cytamine and venetoclax. And that one I really am proud because Devin Stonerock, who's a P4, is actually at Soho right now, well, virtually, and he's presenting the poster findings of that. But we're hoping that we will be able to then expand that also to the multi-center arena in the future.
Cool. All right, I have one audience question here, and I want to ask that, and then I'm going to open up the microphone to everybody else, and maybe that person wants to elaborate on it. But the question was, do you consider the social determinants of health when caring for your patients? And if so, how? I mean, how much do you look into how much money they have, what race they are, where they live, family situation? There's all kinds of health beliefs. Can you talk about how that impacts your practice?
That's a great question. And actually, I was recently talking to Dr. Sweet about our curriculum and teaching students how to approach that, because we don't really, it's something that in the medical field is in its, nascency, like how you actually assess these things or how do you think about them. So when we think about in clinical practice, we have the unfortunate or fortunate, depending on how you look at it, circumstance where we become really aware of the patient's finances, because a lot of drugs are so expensive that we need to work with our other groups like oral chemotherapy to look at their, access to care. So they end up having to tell us how much they make every year. And we end up having to look at grants and what is available to be able to get them their drugs. So from that standpoint, that is something that's always on our minds, and our physicians are very aware as well. So we always make sure that if we're going to start a new therapy on a patient, that we're not going to put them in bankruptcy, because there are studies that show that patients who are bankrupt actually have a lower overall survival. So that is, that's in the literature. That's something that we look at. But, money, like how much you make and whether it's covered, that's just a small piece. There's other things, like you said, or the audience member said, what does their family situation look like? Sometimes we ask a lot of our patients, we ask them to come twice a week for transfusions. We're asking them to get treatments every 2 weeks, very complicated treatments that they have to, I give them calendars to follow. And so we try to delve into some of those conversations through motivational interviewing and open-ended questions, but I can't say that I'm an expert on it. It is something that I do think about a lot. And I also think about not biasing towards making a determination based on something that I think about a patient. So for example, thinking, I should give this patient a simpler regimen because they may not be able to follow the more complicated regimen. That's also the other side of that coin of not assuming for a patient before you've given them all the options. So presenting multiple treatment options and seeing what they think.
All right. Well, I'm more questions are piling in here. What I'm going to do is I will ask them if they don't want to ask themselves, but I want to open up to the audience members. If they want to use the raise your hand function, we will unmute you and then give you a shot to answer your question. And I want to try this. This is our experiment. And if not, I have a few other questions here that have been put in through the Q&A function. But let's see if we can try this. If you can use the raise your hand function, I'd love to know if you can find the raise your hand function on this.
Yeah, it's under the participants. So
Under
if you
okay.
click participants, then you can.
Okay. So while I look for this, because I'm not seeing that option on my interface. So let me ask you a question that somebody else brought in. Does working with patients with an illness like cancer expose you to death and loss more? And how do you deal with that? Because you had mentioned some of these aren't curative.
Yes, leukemia is a very sad disease state to work in. It's also very rewarding for the patients that you do cure. There is a lot of death and loss, and you do get to know patients really intimately and, for a long period of time at times. And it is hard. I can't say I have a magic way to deal with it. I'm someone who hasn't experienced a lot of loss within my family. So I've experienced more, patient related loss than family loss. And it is hard, but I think that what you gravitate towards when you are in this field is ensuring that those patients, you get to know when patients are taking a wrong turn, especially when you read the data and you know how much, you get a sense of how long the patients have. And so a lot of my focus is ensuring if a patient has, I know, probably a couple months, to ensure that patient has the best quality in those months. For example, today I saw a patient that is relapse refractory ALL, and I know that the median overall survival for where she's at is 6 months. However, in those 6 months, she had horrible nausea, vomiting, and I was able to control it. And it was actually very rewarding because she came in and she told me that she's been walking 3 miles and she has not been able to get out of bed because of her nausea, vomiting. And so even though we know we're not going to cure her, she is actually having a really good quality of life right now. And that is, I think, all you can ask for.
All right. Again, if anybody wants to ask a question, raise your hand. Otherwise, they're typing them into me fast and furiously. Let's talk. Next question is, some of these therapies you've been talking about are really expensive. And how expensive is expensive?
Right. So we have therapies, in AML specifically, we have therapies in the $100,000 range. We have therapies in the $500,000 range.
Well, okay, $500,000. None of us have $500,000 in our checking account, and even our insurances. Even if you have insurance, I mean that's just a ton. How does that factor into your consideration?
Absolutely.
Are you willing to give somebody a 2-month less lifespan, but it costs $400,000 less?
Right. So what we do is we look at efficacy first. If there is a drug, so for example, blinatumomab is the $500,000. Actually, if you gave all of the courses, it would end up being over $1 million. But if the drug has good efficacy, we will ensure that patient gets it. If there is, because there's a lot of manufacturer support, there's a very complicated access situation where drugs manufacturers can charge the sky's the limit, but then they offer these convoluted access packages. So if you work at an institution like U of M, you have the opportunity to work with people that know how to navigate that system. Unfortunately, in the community world, I don't really know, if patients are limited, and I suspect that they are, where they cannot get these drugs. But if efficacy is better, then that is what we look at. Now, when efficacy is not better, and this is hard, and this is why I say evidence-based medicine is the most important course that you will take at the College of Pharmacy, because it shows you the skills that you need to know in order to determine, are they pulling a magic trick on you when they publish that New England Journal of Medicine paper, or is it real? And so when you see that the efficacy was better based on a flawed comparator, that's when you really need to say, is this actually better? Because I'm about to put this patient on, $100,000 drug that they will incur debt throughout their lifespan. And is that really appropriate? So it's not straightforward, but efficacy first, and then safety, and then cost. And we really do talk about cost. And there are drugs that we do not provide at Michigan because their efficacy does not warrant their cost.
Who's we? You're in that conversation. Who else?
Yeah, so we is the pharmacy. So the oncology group is the first step. The oncology group and the physician treating, that's the first group that we talk to. And when we all feel the same way, we go to the pharmacy therapeutics committee. And I will say that a lot of times that is the higher barrier, because the pharmacy therapeutics committee is not a specialist in oncology. So it's harder to convince them. They're acting more as the public. And so sometimes we know that the data is not good, and we know that the drug is not good. Sometimes we've even used it in clinical trials, but the pharmacy therapeutics committee is very conservative, probably for a good reason, right? They have to be the balance. And that's how we make the decisions.
Okay. Another question rolling in. These are really fabulous questions. University of Michigan is unique amongst all colleges of pharmacy by forcing, but actually I think encouraging our students to do a PharmD investigations project and to do research. How has clinical research sort of helped you in your career, and how do you contrast the kind of clinical research that you're doing yourself that you just said you were proud of versus research that's being led in industry, say in the heme space?
Sure. So a couple parts to that question. So I think my research is definitely very clinical, very, translational, I guess we could call it, but it's really just clinical research, right? Like I'm looking at outcomes research. And a lot of times we're doing retrospective research where we're not creating the conditions. We are looking and statistically trying to ensure that we look in the most accurate way when we know that retrospective research is flawed. I think a couple things. The PharmD investigations project was pivotal, I think, for me, because I'd never taken a project from beginning to end. And so what I learned in that project, which I did with Dr. Ellingrod actually, was I learned how to do statistics. I had never done statistics before. And even though I probably did it wrong because I was a student, and as a student, you're not going to understand everything. It was the first time where I was actually understanding the difference between conceptually talking about a t-test and actually running it, and conceptually talking about a chi-squared test and doing it, and how do you balance patient characteristics, and how do you put everything together. And so that was extremely important, even though I don't do anything psychiatric anymore. It gave me a leg up. When I came to residency, I could focus on doing interesting research, and I knew how to do at least the beginning of stats. So that was helpful. I think the research in industry is a lot more, and there's a lot of different research, but there's a lot of more benchtop research that gets done, and that's more similar to what I did in undergrad. There's the prospective clinical trials are run over many, many years. And there's a lot of nuances of protocol changes and things like that. So I think they're very different types of research, but the skills that you need to have, I think, to design a good study are the same. And so I think that that's the point of the PDI project, is to learn how to design a good study and to get your hands wet in trying some, the statistics part of it.
All right. Well, I don't see any other hands raised here, and I don't want to keep everybody from their dinner. I want to keep these at a reasonable amount of time, but I also want to give you a chance to plug what you want to plug. First thing I have to say is happy birthday, by the way.
Thank you.
Yes, that's got to slip that into here. But anything, you got a lot of students online here with you. Anything you want to talk about, whether it's Farm Song or residency or a great networking tip that you have, what would you like to plug here?
Sure. So there's definitely a lot of opportunities for students, for all of you who want to get involved in oncology, or even if you don't know that you want to get into oncology, but it sounds somewhat interesting. There are, and I think that in the pamphlet, there's a couple opportunities that I mentioned. So Farm Song is a group that Dr. Kraft leads, and it gets you to understand that access piece a lot better, because the students who are in that group are actually writing appeal letters, looking at the clinical data to try to get those drugs approved for patients. And that's a service that is really great. And honestly, I think the students get a lot out of it. Also, PDI, so we have so many different people in oncology that can lead pharmacy investigations projects. So definitely reach out if you are interested. I find that, that's definitely one of the more rewarding because you get to know the students for many years. And I think one thing that you taught me, Bruce, that I'll pass on is that I remember as a P2, I didn't know what I wanted to do. And I came to your office and I was like, I don't know what I want to do. And I feel like I'm just floating through pharmacy school and I'm a little afraid. And you said, and then we had this conversation and you asked me all the things that I didn't want to do. And I told you, well, I don't like this and I don't like that. And so I think one of the big things is to recognize what you don't want to do as just as much as what you do want to do, because it will allow you to narrow your focus. And then when you start finding things that you want to do, then those other things, you don't want to do them, so they don't distract you. And I think the last thing I would say in terms of networking is that it feels very uncomfortable when you're a student to network. I was uncomfortable as a student, but I think as you get to know people, and so you joining this is one good way of knowing people, you find commonalities. And networking is nothing more than just talking to others. And so if you talk to others like you talk to your friends, you have a common trait with everyone in the pharmacy world, which is that you're studying pharmacy. And everyone who's a professor or in the world of pharmacy wants to talk to people that are going to be future pharmacists. We want to pass along these little pieces of things that we think are important. So never be afraid or feel like it's uncomfortable, because the people on the other side know how important it is to network. And we also find it very rewarding. That's what I enjoy the most about my job. And what I remember the most is all the students that I've had that now are practicing oncology pharmacists, and the residents that I've trained. That's what you get the most out of.
I had another question come in. It's a little different, but I'm going to go back to this oncology stewardship idea. And I was wondering, P4, did you end up going to a drug company or FDA or anything like that? And is for example, working at the FDA, is this a way to practice oncology stewardship? I mean, do they need to be more careful in their approval process, or do some of the things that you're saying to have that in their consideration? I mean, is there a role maybe even for some of the people on this audience to think about other ways besides having a direct clinical practice?
Right.
Could you do this through FDA or industry or some other?
That's a fabulous question. I mean, yes, the FDA has, loosened their restrictions significantly, it seems like, in the last, 5 years or so. And absolutely, I think the difficulty is, as someone who works in the FDA, you may not be in tune with what the clinical practice is. So I think that it's a collaboration. I think the FDA needs to collaborate more with the people that are treating patients, and not just read the study and assume, right, that what is being said as the standard of care is the standard of care, because that's the biggest problem that we're running into. But absolutely, I think getting involved with the FDA is a great way to, or even, even if you don't want to be in the FDA, but you're interested in oncology stewardship, doing a rotation in the FDA. I wish I would have done that. I didn't think that far ahead when I was a student, but understanding the different places. I worked in industry and undergrad, so I understand industry somewhat. But understanding all the different pieces, I think, is key to solving the problem, because I'm doing it case by case, right? And I'm trying to create awareness, and our group is trying to create this oncology stewardship mentality, but industry isn't thinking about it. FDA isn't thinking about it. So I think that's a great question, and definitely I would encourage that. Yes.
All right. Well, thank you. I want to thank you for being my very first guest. That's awesome of you to do that. A couple other things I wanted to say. One is email the best way to get a hold of you?
Yes.
If there's more questions from the audience?
Absolutely.
All right. And I want to say to the students who are online, next week, we're going to do this again. We're going to have an entirely different kind of topic. We are going to have the group from the University of Michigan who runs the residency interview process and how it's all changing because of COVID. We're going to walk through what the processes are. So take a look Next Friday, it's going to be at 5:30. I'm picking different days so I can avoid exams and stepping on top of student organization events. So Friday at 5:30, Kate and Mike Kraft are going to be in as guests to talk about what the process is going to be for trying to find a residency. If that's something that interests you, particularly in this COVID era, because I have no idea what it's going to be like, that's what the next show is going to be about. So thank you so much, Dr. Benitez. It was really a great time. And anybody who's got further questions can reach you by email that's on the screen right now. Thanks for being my guest.
Thanks for having me.
Good night, everybody.